Declan, is COVID going downhill in Australia?
Well, we've had a problem in Melbourne for a few months, so we've had a severe lockdown. Macarand, as you probably heard, still ongoing, but the numbers are actually very small. You know, one case today, but still all the bars are closed, all the restaurants. So we've had an aggressive strategy to keep the numbers low, and it's been successful, but quite hard work for everybody.
I know.
Which it also means now the airports are closed. You know, we can't obviously have people flying in and out from Europe and the US. So I think it'll be very difficult for a while.
Yeah. No, it's India is going downhill, but it's in different parts of the India, different phase of pandemic. Luckily, it's going downhill, so we are able to operate now.
Oh, nice. So it's already 4 o'clock. I think we can start now. Sorry to say. Assalamualaikum warahmatullahi wabarakatuh. Good evening. Everybody will join us for welcome back again. I mean, for the participant who join us, the one of the initiative from our organization now is the chance for Indonesian section of Uro-Oncology Urology that we perform ICU International Series Uro webinar. We are very lucky now because we have 3 distinguished speakers, because especially they are very busy actually, and absolutely, because they are several times comes to Indonesia. They are love go to Indonesia, but due to the COVID, I think we miss them directly. But with this webinar, we can have discussion about the future or the new or the recent management of uro-oncology cancer. Due to the technical things, we changed the topics. Supposed to be, the first is for Professor Declan Murphy, the second one Dr. Makaran Kochikar, the last is Dr. Jeremy Theo. I think we will start with Dr. Makaran Kochikar. Dr. Makaran Kochikar is now he still have a board of director in SIU, and then he's come from India and many training, one in Mumbai and then in Cambridge. Of course, a lot of publication has been published. Dr. Makaran, we're going to have a talk about the role of cytoreductive nephrectomy in multi-drugs targeted therapy in kidney cancer. So please, Dr. Makaran, to give a talk.
Thank you very much. Are you able to see my screen?
Yes, but still not in the.
Still not able to see?
Yes, but not in this presentation mode.
Okay, just a second.
Yeah.
You can see me now?
Yes.
Okay, first of all, thank you very much for inviting me to be part of this wonderful program, which is labeled as ICU. Thanks, Dr. Agus, thanks the Indonesian Urological Society, and I must thank one of my very good friend, dear friend, Declan Murphy, to allow me to come first, because for some reasons I need to really sort of finish the talk and go as early as possible. So apologies for that. The talk which I am going to give you is the role of cytoreductive nephrectomy in multi-drugs targeted therapy in renal cancer. No conflict of interest. The talk is based on one of the big reviews I did a few years ago, and a lot of things have changed since then. At that time, we were thinking that cytoreductive nephrectomy is really important, along with a combination of targeted therapy, but a lot of things have changed in last year or so. Before we come to the conclusion, or before we give you sort of what is the rationale of using or not using cytoreductive nephrectomy, I thought let us peep into the past. That will give you an idea what we are doing is right or what we are going to do is wrong. Historically, we used to do nephrectomy and metastatic RCC for palliation, pain relief, for local infiltration, hematuria, and control of severe paraneoplastic manifestations. Survival benefit was never an endpoint. And there were case reports saying spontaneous regression of metastasis, but they were very anecdotal, less than 0.4 to 0.8%. So these were historically reasons why we used to do sort of nephrectomy. Then came the era of cytokines in 1980s, or we call as immunotherapy era, where we use interferon alpha 2b, interleukin 2, and between these two, interferon alpha was safer and easy to use, low side effects, but not was very effective. You had interleukin 2, which was toxic, needed ICU care, which was expensive. The response rate was about 20%. These two drugs which were used, and they were famously mentioned into study, which was EORTC and SWOG study. They were two randomized controlled trials. And you would know the study which was done 2001 and 2001 here, these two studies here, it was again combined analysis by Rock Flanagan, and it did suggest that 1 year survival with nephrectomy and interferon was better than interferon alone. And similarly, if you use SWOG study, it was better with adding nephrectomy. Subsequently, these studies were also sort of analyzed in different way. What were the criteria then? Clear cell histology, metastatic RCC beyond lymph nodes, no brain metastasis, IVC thrombus below hepatic veins, no prior therapy, and a good performance status. Both these trials, the regression of metastasis was 6%. All of them could tolerate cytoreductive nephrectomy, very low operative deaths, and immunotherapy could be started within 1 month of nephrectomy. Even metastatictomy, even a solitary at that time, was never done in that trial. This was 2015 Cochrane review, and it did suggest that it has a modest benefit compared to other commonly used treatment. So this combination can be considered rather than giving only immunotherapy. Now, then came the era from 2002 onwards was targeted therapy. What do you mean by targeted therapy? We had TKIs, monoclonal antibodies, mTOR inhibitors. So the combination of cytoreductive nephrectomy and targeted therapy started, and obviously there would be studies to compare targeted therapy alone. There have been many studies. So in conclusion of that, still there is no level of evidence to suggest that it should be a combination CRN plus targeted therapy. But we do have potential survival advantage, which is clearly seen. There are two distinct studies. One was in 2011 by Chouari, which showed 314 patients, 201 CRN, cytoreductive nephrectomy, 130 no CRN. And what was found that there is twofold increase in the survival, 19.8 months who had a cytoreductive nephrectomy with targeted therapy as against to only 9.4 months. There was another study by Zini with 5,000 patients, which was population-based study, and it did suggest that there is 2.4 greater risk of death if you don't do cytoreductive nephrectomy. Come some time later, and then there was also a study which was found out utilization of cytoreductive nephrectomy. It was based on severe data, and it did suggest that survival was better if you have cytoreductive nephrectomy. The paper also mentioned that as soon as targeted therapy was sort of started, there was slight drop into the performing cytoreductive nephrectomy, but this was not a global phenomenon. This was IMDC, International Metastatic Renal Cell Carcinoma Consortium paper, and it did suggest that if you have cytoreductive nephrectomy, certainly you will have a better survival, 20.6 months versus 9.6 months. But remember, in this paper, this sort of large series or meta-analysis, it did suggest that if you have performance status of 4, 5, 6, they would not benefit for cytoreductive nephrectomy. This was another meta-analysis published later on in 2016, analysis of 11 non-randomized trials, more than 39,000 patients. So there was a 54% reduced risk of death if you have cytoreductive nephrectomy and targeted therapy. So putting these two things in historical perspective, both these eras, we found survival benefit if we combine cytoreductive nephrectomy along with immunotherapy or targeted therapy. And by just doing targeted therapy, it is not going to have much benefit. That was the conclusion of these two important eras. So let us find out how the CRN work. There have been various studies. Why I put this slide? Because nowadays we are talking about Carmina trial. We are talking about multiple drugs which are available, as the title of this talk suggests. And people are questioning whether we should be really doing cytoreductive nephrectomy. The response is pretty good. For them, my argument is there is significant reduction in the disease burden and the development of new metastasis. It's an immunogenic tumor. It prevents the immune mechanism to fight against the metastasis through the various factors and signals. It restores the immune system, and CRN leads to low-grade acidic systemic acidosis, disrupting the tumor environment. So it definitely has a role of performing cytoreductive nephrectomy. Then the next question is, what is the optimal cytoreductive nephrectomy? Just take the kidney out, or what do you do? I personally feel you need to have an R0. So the paper here from BJUI in 2010 suggests that if you do nearly 75% of tumor volume debulking, then it's beneficial. But if you leave large amount of lymph nodes, you leave large amount of disease behind, it is not going to be beneficial as such. What about tumor primary is small and has extensive metastasis? Can you do nephron sparing surgery? Can it be called a cytoreductive nephrectomy? Obviously, it can be, and the effect is seen in these studies where nephron sparing surgery can be considered as a part of cytoreductive nephrectomy. The only thing is, in this study, there were complications. The perioperative complications of nephron sparing surgery in CRN were slightly higher as compared to a standard nephron sparing surgery in a non-metastatic disease. What about cytoreductive nephrectomy in IVC thrombus? There is obvious surgical risk, mortality, delay in targeted therapy. It can be if the patient goes into complications, and we are questioning about survival benefit. This paper from Journal of Urology in 2017 by Abel and his group does suggest there were about 427 patients. If patient has IVC thrombus above diaphragm, poor risk group, systemic symptoms, sarcomatous histology, these patients do not benefit much from cytoreductive nephrectomy. So maybe you can choose and decide whether you want to do cytoreductive nephrectomy in this group of patients. So in nutshell, it has a role, it has a philosophy why we do it, and it has a benefit. But which one will benefit? I think the selection is very important. Good prognostic factors, good performance status, no sarcomatous histology, and you look at NCCN guidelines. If you have lung metastasis only, good prognostic factors, good performance status, it works very well. What about exclusion criteria? Which patients you should not be doing it? Those who have high LDH, increased corrected calcium, hemoglobin less than 10, low performance status, brain metastasis, sarcomatous histology, elevated neutrophil and platelet count, and the risk groups, favorable, intermediate, poor. I think intermediate poor do not do very well if you do CRN in these patients. What are the disadvantages? Why people are talking about using multi-drugs targeted therapies rather than cytoreductive nephrectomy? You can have a morbidity, obviously, increased mortality at a higher stage tumors. There could be delay in starting targeted therapy. People are questioning, I told you the advantages of cytoreductive nephrectomy, but people are talking about the adverse effects of immune system. And we really don't know who are going to respond well or who are not going to respond well. So you may have to choose which are good responders, except we know patients with clear cell have better response than the non-clear cell. I personally feel this is not something I'm suggesting to all over the globe or for everyone as such, but I personally feel looking at this confusion, you can pick and choose your patients properly. Use neoadjuvant targeted therapy and combine with cytoreductive nephrectomy. You don't delay the systemic therapy. So what you do is you use 2 cycles of sunitinib or pazopanib, give for 2 months, reassess the response. If you have a PR, partial response or stable disease, you can do cytoreductive nephrectomy followed by targeted therapy. If they have progression, perhaps you can omit cytoreductive nephrectomy. This is not something that is going to be followed by each and every one, but this could be a logical thing. In support of what I'm saying, I'm just showing you a couple of cases in a real life scenario. This guy who has a large left-sided tumor with an IVC thrombus and a thrombus around here as well, lymph nodes here, lung metastasis. This guy was treated with pazopanib. Look at his pre-op chest X-ray, and then you see pre-treatment chest X-ray and a post-treatment chest X-ray. A fair amount of response in about 2 months' time. Then he gets cytoreductive nephrectomy. The level of thrombus is also significantly low. I'll give you another example. This was 50-year-old guy, diabetic, hypertensive, right-sided abdominal pain, gallstones. He had a LUT poly done. He had a pain and found that he has a large renal mass with liver metastasis, lung metastasis, adrenal metastasis, and few metastatic deposits in the rib cage. So this was at presentation. Adrenal metastasis, what you can see here. You can see it's a large tumor here with an extension into renal vein and IVC, lymph nodes around. maybe you can do the surgery as such, but he has multiple metastases. Biopsy, clear cell RCC. This was 2 years back. Pazopanib was started. Now we could start some more other drugs like mTOR inhibitors or new other immune checkpoint inhibitors. He responded very well. So 5 months down the line, you can see the tumor has regressed, the renal vein thrombus has gone, tumor is much better, adrenal tumor metastasis has also gone down a little bit, and a lot of lymph nodes have regressed. Even the lesion in the lung and liver also regressed. He was still not keen. That can happen. People responding very well, they say, we will not need sort of cytoreductive nephrectomy. So we continued, and thereafter we did his cytoreductive nephrectomy. And this was after almost like 8 months. And you see, this is what almost gone the tumor there, and this was all removed. Now he's still on targeted therapy. See, almost like 2 years, he is disease free and doing extremely well. So this is now the adrenal metastasis. This was all residual disease what he had. That was adrenal metastasis what you can see there. And this was a histology showing post-TKI changes in the kidney and adrenal with significant shrinkage with small amount of viable disease. So it's nearly 2 years, no further metastasis. So it's done very well. So you can use this kind of combination therapy, use your own judgment as such, rather than sticking to a particular guidelines and looking for level 1 evidence. So question is, when do you do timing of cytoreductive nephrectomy? As this patient who responded very well, he wanted to wait for some more time and wanted to in fact avoid nephrectomy. There have been a lot of papers suggesting when we should do nephrectomy. This study, multi-extension study of 35 patients, group 1 CRN followed by sunitinib, sunitinib followed by CRN, and they looked at response on RECIST criteria. Group 2, which is a combination like this, has a better response. What was important in this study was at least you give 2 cycles of sunitinib, and then perhaps go, if the response is good, go for cytoreductive nephrectomy. And another paper here suggesting that you can use something like this phenomena, at least use for 2 cycles and take it further. Sometimes study is going to absolutely tell us immediate versus delayed cytoreductive nephrectomy, and the data is still mature, not matured as such. What about complications? I mean, are these drugs safe if you decide to use neoadjuvant therapy? I think it is safe, but they can delay cytoreductive nephrectomy. You can have bleeding, you can have non-healing wound, dehiscence, thromboembolic events, and hypertension. It is not really neoadjuvant. A lot of people would call. People would say it's a preoperative therapy. But whatever you call, you can use this therapy. Beware, these patients can have wound dehiscence, thromboembolic episodes, acute mitral infarctions, and bleeding, and it can range from different kinds of drugs what you keep on using. Now I'm coming to the crux of situation, so-called Carmina trial. This result came about 6 months, 9 months ago, and medical oncologists are now saying that why do you need sort of a cytoreductive nephrectomy? Let us look at this paper objectively. This paper was published in August 2, 2018 in New England Journal of Medicine. What did the paper say? Out of 450 patients from 2009 to 2017, they looked at people who had sunitinib alone or patients who had cytoreductive nephrectomy along with sunitinib. And what did it suggest? That a median overall survival was 18.4 months, in sunitinib alone, as against to 13.9 months in nephrectomy sunitinib group. So sunitinib alone was better. Conclusion-wise, it was not inferior to nephrectomy, and they were suggesting sunitinib alone can be a treatment of choice in metastatic RCC. And this was a graph which was published in New England Journal of Medicine showing distinct difference here. And this was progression-free survival with sunitinib alone. Now look at the comments all over the globe. There have been a lot of people who have made comments, written editorials, have interviewed, and none other than Bob Flanagan, who actually sort of did a combined analysis of SWOG and EORTC in interferon and interleukin era. He did suggest that Carmina trial is not a final word on cytoreductive nephrectomy. And the reason being, there have been many retrospective database studies looking at cytoreductive nephrectomy results. I think it's an unfortunate thing if you look at it from the point, just saying that people don't need nephrectomy. And I think this trial does not change the real out practice, but you have to be very, very rational and practical in using those. What is the criticism? If you look at the study very carefully, the trial was done only in France. More than 50% patients were poor risk, so the outcomes were going to be poor. The trial only for intermediate risk and poor risk. Strict adherence to protocol was not followed in this study. Few patients did not have CRN following sunitinib, and few did not continue with sunitinib and had CRN. So the whole data can be sort of a bit taken with pinch of salt. This is not a sort of a standard randomized controlled trial. It's something called as a non-inferiority trial. Many studies have shown initial CRN followed by TKI has a better outcome. And this is not RCT. We don't have RCT so far. And again, sunitinib is not an ideal drug, we all know for sure. There are so many other new drugs which have a lot of promise, which are showing good response to all different types of renal cell carcinoma. So ultimately, it is do what is best for the patients. Now, this was in March 2019, another article in New England Journal of Medicine, combination therapy as a first-line treatment in metastatic RCC. And I would like to tell you the different permutations and combinations. You have combination of pembro plus axitinib versus sunitinib alone, trial of avelumab plus axitinib versus sunitinib alone, or nivolumab plus ipilimumab versus sunitinib alone. Large number of patients, almost more than 800 in each and every group. And you see here, the combination therapy group, median progression survival in month was 15 months, 13 months, and 12 months. And this is almost comparable when you use nivolumab and ipilimumab. Pembro slightly better, pembro-axi slightly better than sunitinib. And here, avelumab-axi slightly better than sunitinib. So we are having some different drugs. But does it mean that you don't do cytoreductive nephrectomy in these patients? I really have doubt on my own. So in conclusion, what I suggest, as of today, we haven't reached a stage, there is no level 1 evidence suggesting that you can get away by doing cytoreductive nephrectomy. So my answer to the question posed by the organizers, yes, there is a role of cytoreductive nephrectomy. It has to be used judiciously in good risk patients. It has to be supported well with targeted therapy. You can use a combination of neoadjuvant, see the response, select patients, treat them, use R0, use a time gap adequately, and follow them up with targeted therapy. This is what I personally feel. So CRN remains integral part of a treatment of metastatic RCC, mainly for the patients with good performance status, life expectancy more than 12 months, and in absence of adverse prognostic factors. It has survival benefit in immunotherapy era, and the results in targeted therapy are very encouraging. Timing of CRN in the area of ongoing research, but certainly, we can't get away with cytoreductive nephrectomy just on the pretext that these multi-drugs or new drugs are going to be very, very useful. Thank you very much. I'm open for questions and answers. Thank you.
Okay, thank you, Dr. Makaran. It's very nice talk and very nice overview about the cytoreductive, because we know there is always a debate after the Carmina study, but you give us a very nice insight about what is the current indication for cytoreductive nephrectomy. Is there any question? You can put it on the chat. Before that, I have a question, because I saw your slide that there is a contraindication for the sarcomatoid histology. So you suggest we do the biopsy first before we start the how to say the immunotherapy or TKI inhibitors, or before doing cytoreductive nephrectomy?
It depends on what kind of histology you have. Obviously, when you want to plan this therapy, you need a biopsy. If the biopsy shows primary renal cell carcinoma with sarcomatoid changes or rhabdoid changes, we know the prognosis is not very good. We also know the varied response between TKIs as well as mTOR inhibitors and immune checkpoint point inhibitors. So my argument to this is the patient performance status is good. The best therapy what you can offer is try and achieve as much R0 as possible and put them on clinical trial for these drugs. But if the patient has primary unclassified disease or purely sarcomatoid histology, come what may, the writing is on the wall. So you have to pick and choose and decide. The performance rate is good and you feel you can help the guy, you go for CRN. Otherwise, I think the outcome is not going to be very good.
Okay. The second one is actually, I saw your experience with the TKI inhibitors. but we know now, like you said, there will be multiple or combination therapy. So do you think that we are going to apply that one? I mean, we use the multiple therapy, drug therapy, and then we see is there any good response or stable response, then we do we still do the cytoreductive nephrectomy. What do you think about that?
Yes, certainly. I think as we have tried in previous sort of studies, we can always give something like, see the good responders, start them with targeted therapies. You can use Axi, you can Pembro, these drugs. But mind you, that side effect profile, what you're talking about,
Yeah.
Pembro, the cost of what you're talking about. So you look at all those aspects. And if the response is pretty good, they regress significantly, then you go ahead and do the surgery and then put them again on sort of targeted therapy. So the cost issue, the tolerability issue, the side effect variable profile issue, and ultimately what you are going to gain out of it. That is also important.
There is a question from Dr. Saukar Vijay. If we found non-clear cell metastatic renal cell carcinoma, do you still there is a role of neoadjuvant treatment or tyrosine kinase inhibitors?
It's a very, very good question because so many studies have been based on sort of clear cell histology. But if you look at now even the adjuvant therapy trials, if you look at sort of neoadjuvant therapy trials, people have been using these drugs for non-clear cell histology as well. And I'm also surprised. I mean, there are cases where there is fair amount of response into non-clear cell histology. So the answer to your question is yes. I think these drugs can be used, and you can get response as against to what we used to see in the past.
Okay. Any other question from the others? Actually, because we still have time, actually. So, yeah, I mean, I think in our practice, we are a little bit because we always found very big tumor and a lot of metastatic. So, what is about your recommendation for us about the classification? Should we? I mean, we should do that directly now, or please, what is your comment for that?
I think horses for the courses. I mean, that is very simple to answer. I think if you feel that patient can sustain the surgery very well and you're able to do more than 80% of debulking or sort of disease clearance, I think you can go ahead and do the surgery, and depending on the final histology and staging, you can put them on multi-drug therapy or whatever combination you want to use it. If you are in doubt, whether it is going to help or not going to help, large tumor bulk, IVC thrombus, multiple metastases, I would go by neoadjuvant or pre-operative targeted therapy first and see whether they respond very well. And if they respond very well, then certainly yes, you do it. Otherwise, you don't do it. Last but not the least, there are people who keep on, using that kind of information in the guidelines or the results just for the sake of doing nephrectomy for hematuria. I think the days are gone for doing nephrectomy just for hematuria. There are so many other things you can do, therapeutic embolization, you can use drugs and so many other things. For pain, I would not do nephrectomy just for a pain. Even I'll be skeptical of doing nephrectomy for paraneoplastic manifestation, what was said in the past. So I think my judgment would be good performance status, upfront nephrectomy followed by targeted therapy. If you are not sure how he is going to respond or whether he will sustain the surgery, start neoadjuvant, see the response, and then undertake cytoreductive nephrectomy.
Okay. Is there any further question? I think that's all question for you, Dr. Makaran. Thank you very much for joining us. Send my regards to your father.
Yes.
So I hope everything you will fine.
I
I think all the participants pray for your father. We hope everything was okay now or in the future. And thank you once again. So we continue to the next speaker. So please, if you want to leave, thank you very much.
Thank you very much, Dr. Agus, and thank you, Declan, for allowing me to come in first. Thank you.
After the Dr. Makaran, we move to the talk to Professor Declan. Professor Declan Mukri will give a talk about the recent and future theranostic PSMA treatment in prostate cancer management. Professor Declan Murphy is a consultant urologist and director of genitourinary oncology in Peter MacCallum Cancer Center. It is a nice center. I have a chance to visit there twice, actually, to see the uro-oncology service there with supervised Professor Declan. It's very nice. Professor Declan also one of the pioneer for the PSMA diagnostic and the treatment, and surprisingly, actually, not in every country have a PSMA diagnostic or treatment. So I think that will be a good for us to hear what is the future of the PSMA treatment. And Melbourne is one of the pioneers to expand this indication for the better prostate cancer management. So please, Professor Declan, the time is yours.
Thank you, Agus. Thank you very much for the kind introduction. And yes, of course, we remember very fondly when we were able to welcome visitors to Melbourne. And of course, I've enjoyed visiting Indonesia very many times. Today, I'm wearing a shirt that Rainy Umbas gave me a few years ago when I visited him. And so I thought I would wear this in lieu of being able to travel and enjoy the usual fantastic Indonesian hospitality. But hopefully those happy days will come again, of course. We look forward to that. And thank you for asking me to discuss this, I think, hot topic for sure, PSMA Theranostics. So the use of PSMA targeted treatments for prostate cancer. And I'm very happy to update you on a few of our recent trials in this area. And I think we as urologists should be interested for reasons I'll come to in a few moments, because this therapy is moving forward, not just for CRPC patients, but increasingly the patients that we see as urologists. So I hope you enjoy our perspectives on it. And I'll talk about three areas. I will talk about theranostics, of course, mostly, but I wanted to first of all just make a few points about PSMA PET-CT for imaging. And of course, this has been a hot topic for a very long time. I'll acknowledge my fantastic colleague and collaborator, Michael Hoffman, who's professor of nuclear medicine at Peter Mac. And myself and Michael have worked very, very closely for the past 6 or 7 years developing the PSMA imaging program, and then more recently the Theranostics program. And I know many of you know him. He's a fantastic guy, and we do a lot of this work together. So PSMA, of course, is now well described. It's a great target. This is a normal PSMA PET scan. So we know that, of course, it's also expressed in normal tissue, as you see here. But the reason it's interesting to us as urologists is it's very highly overexpressed in prostate cancer, especially in nasty prostate cancer, generally speaking. And we've known about PSMA for very many years, and there have been antibodies directed against PSMA for imaging. You'll see on the left of the screen here, the old Prostacint, which was an antibody-directed PSMA imaging years and years ago, was useless, of course, for lots of different reasons. And it was only in recent years when these extracellular small molecule ligands became available, gallium PSMA 11 being probably the most common one, but more recently other ones, fluorinated ones, that we began to see really striking images for prostate cancer patients, and that's driven a lot of the interest. So I think it's fair enough to say that because of these lovely images we've been seeing from many centers around the world in the past 5 or 6 years, whole body scans showing primary regional lymph nodes, bone disease, visceral disease, all in one scan with very striking tumor to contrast ratio. Clearly, it's emerging as a potential new standard that we should be used for staging our prostate cancer patients. So we realized this back in 2015, once we'd been using this scan for a year, and we set about designing a prospective randomized trial to compare PSMA PET-CT with conventional imaging, because we knew no matter how nice the images are, the only way we'll get these things accepted or reimbursed will be to do a trial to demonstrate that PSMA PET-CT is better than conventional imaging. And so that trial is called the Pro-PSMA trial, and we were very pleased to have it published in The Lancet just a few months ago, the results of this trial. So obviously getting it into the Lancet is a good achievement for us. Michael is the first author, I'm the senior author, and the group involved in this are a very multidisciplinary group from 10 sites around Australia, led from Peter Mack. It was a great collaboration between urologists, radiation oncologists, nuclear medicine physicians, trial coordinators, radiopharmacy. And we recruited this trial, a 300-patient trial, 6 months ahead of time, and then had the data mature for early this year, such that it got published in the Lancet. We were supposed to read it out at the EAU at the same time. It was designed to be one of these synchronous presentations, but of course the EAU got cancelled, but we went ahead and published it in the Lancet. So I want to show you this briefly because I think this is important to know. It's definitely important for the trainees there to, to be aware of these important trials that are considered landmark trials, level 1 evidence to show something is better than another thing. So we recruited 300 newly diagnosed high-risk prostate cancers, or indeed unfavorable intermediate risk. So they either had to have a PSA above 20, Gleason grade group 3, 4, 5, so old-fashioned Gleason 4+3 or higher, or high clinical stage. So high risk or unfavorable intermediate risk. So they were newly diagnosed, and we set about staging them using conventional imaging and PSMA PET-CT. They were randomized such that half the men got conventional imaging first and half the men got a PET scan first. And then, unless there was a huge amount of metastases, they all crossed over and got the opposite scan. So the average age, very typical for high-risk prostate cancer, 68, PSA around 16 or 17, very high-grade cancer, and indeed a lot of them had clinical T3 cancer. So almost all the patients did have their first-line imaging, and then they cross over and got the other scan. So this was important because then we could have a prospective, very tightly quality-controlled comparison between conventional imaging and PET scanning, because nearly everybody got both scans within a couple of weeks of each other. And then to determine the truth of which scan was right and what findings we had some criteria, which I'll explain in a moment. We also recorded the management impact of the scan. So this is important for getting reimbursement for these scans. You need to say, what's my plan? And then you do a scan and then say, okay, what's my new plan? And then do a different scan of what's my new plan. And that's called management impact, which I'll come back to in a moment. And the reference standard was defined at 6 months by either having hard criteria, like, for example, lymph nodes at lymph node dissection, or sclerosis on subsequent bone scan. And that would be, yeah, definitely that was a metastasis. But of course, not everyone went on and had surgery. So we had a combination of soft criteria, which also was the reference standard. So in other words, this is what we said we used to define which scan was more accurate. And here, just a couple of examples from the trial. Here's a patient with PIRADS 5, grade group 5, Gleason 9 cancer, big PIRADS 5 lesion. You can see it very nicely matched up on the PET scan. On the conventional imaging, he was M0, but cross over to the PET scan, and you can very clearly see these internal iliac and obturator lymph nodes. And that's a very typical finding in this study. And you might argue it doesn't really matter. He probably would have had a lymph node dissection anyway, but it does show you the striking information you get. And here's another one, a 46-year-old, again, grade group 5, Gleason 9 cancer, presented with lower urinary tract symptoms. And he had a CT and bone scan first, which was normal, and then crossed over to the PET scan. And look here on the whole body MIP, you can see these extensive retroperitoneal lymph nodes, which were not apparent on conventional imaging. They look very, very prominent here on the PET scan, but of course there's a big halo effect around some of these lesions with a high SUV max. So as you come down into the retroperitoneum, we'll see there's a node that's impossible to see on conventional imaging, and so on and so forth as we drop down into the pelvis. So there's very significant management impact now for this 46-year-old who essentially has metastatic disease. He's got M1A disease based on his retroperitoneal lymph nodes. So what did we find in the study? Well, here's the key message. The primary outcome was accuracy. And what we showed is that PSMA PET-CT was 27% more accurate than conventional imaging when compared with the reference standard. So CT bone scan got it right about 65% of the time. PSMA PET-CT got it right 92% of the time. So big difference, tight confidence intervals. So we can clearly say PSMA PET-CT is superior for this primary endpoint. We also had important secondary endpoints like management impact, as I mentioned. So when you did a CT and bone scan, the information you got changed the plan about 15% of the time. But in the men who had a PET scan first, it changed the plan 28% of the time, mostly because you're seeing more accurate information. And even when you cross over to the other scan, so if you had a PET scan first and you crossed over to the CT scan, really it didn't have any management impact. But the other way around, it did. So you had a CT and bone scan, and then you cross over to the PET scan, and there you go, 27% of patients had a significant management impact. And that's all detailed in the manuscript. Equivocal studies are very important. So you're very familiar with this. If you organize a CT and bone scan for these patients, 1 in 4 of them have equivocal findings. Vague thing on a bone scan, which often lead to more scans or biopsies and so forth. And that was very unusual in the PET scanning. So this is an important consideration for reimbursement as well. And finally, radiation dose, much lower. So 19 millisieverts in conventional imaging, but only 8 millisieverts. So again, another important thing we can say to our funders to say, look, a shorter trip, 1 trip to the hospital, less time in the scanners, less radiation, less equivocal studies, and more accuracy. And all that makes a difference. So the strengths are all there. There of course are some weaknesses. We probably overestimate the sensitivity because not everyone had a lymph node dissection and so on. And of course, will seeing all this information lead to better outcomes for our patients? We don't know. That's not something that pro-PSMA could answer. And this is just the infographic that summarizes that. But I think you'll all agree it's quite convincing now. Prospective randomized trials showing PSMA PET-CT has superior accuracy. But of course, something else will flow on from that, and that's the theranostic thing, because one of the novelties of PET imaging is if something's very avid on a PET scan, you can label the PSMA ligand with not just something to see the cancer, but something to treat the cancer. And that's the principle of theranostics, which I'll come to. I suppose I should say PSMA PET, we're very optimistic that this will become more available everywhere. But of course, there's all sorts of constraints on that. In some countries, it's expensive to do this. In our country, it's not expensive. So we believe that there's a real argument to try and roll this out everywhere. It's widespread in India, lots of access in Germany, and it will be reimbursed in Australia because of pro-PSMA. So I hope that we will see it available in other centers around the world, including in Indonesia as well. So theranostics, let's talk a bit about that. I'm going to split this into 2 sections. One is to talk about the data already published about CRPC patients using lutetium PSMA. And then I'm going to talk about where I think it's all going. So just to briefly explain with this slide from Michael about what we mean by theranostics. So as I explained, here's a patient with mCRPC. This is his PET scan, just with a PSMA 11 PET scan. But then what you can do is label the PSMA with not just something to see the cancer, but something to treat the cancer. And this is a beta emitter, 177 lutetium, which is a very active thing with a short half-life. So what you'll see here is the SPECT scan. So this is the scan we do a few hours after a lutetium infusion. And what you see here is the dose of radiation getting into the cancer. So these high areas here in the adrenals and bones, etc., are getting a big dose of radiation. And that's what theranostics mean. It's a diagnostic companion with a targeted therapeutic. And the first reports of this came out of Germany in 2014 and published in 2015. And we were very interested in this when we saw it. We'd already had experience of PET imaging with PSMA, but we thought PSMA theranostics was well worth a look at as well. So again, at that same time, we set out designing a prospective trial of PSMA lutetium in patients with very advanced prostate cancer. And this trial, which was our phase 2 study, was published in Lancet Oncology in 2018 and is still the only prospective study of lutetium in this setting. Everything else is retrospective, so another important study. And we followed that up last year with an extended cohort. The first cohort was 30 men, and then this was 50 with the longer term follow-up as well. So I'm going to show you some of the data from that. So these were men with really bad CRPC. They'd all pretty much exhausted all lines of treatment. Almost all had docetaxel or Abi or Enza and so on, and they had no other options. Lots of them had severe pain and so on. So we took a deliberately no-hoping group of patients to trial this on. We aim to get 75 patients into the study. We screened 75, to get 50. We excluded patients for these reasons here, either low PSMA expression, so that they didn't have a high SUV max, and we did FDG PETs on everyone. And if we saw a difference between the FDG and the PSMA, I'll come back to that in a second. Likewise, we said you're not eligible. So here you go. Average PSA coming into the study was 190 with a PSA doubling time of 2 months. So these poor guys were going to die within 6 months with this very fast doubling time. And this is all the prior treatments they had. 84% had had docetaxel, half of them had had cabazitaxel as well, and almost everybody had had Enza or Abi. Lots of high volume disease, especially bone. And we did dosimetry very precisely. I've shown you some examples of this, but we are very interested in what sort of dose you can get into this. So we have a big research program into measuring the dose using SPECT-CT, and this was a separate study that we published on this. So the primary endpoint of this was safety, and the bottom line is it's very safe, actually, even in these unwell men with very extensive disease, very heavily pretreated. It's very well tolerated. These are all temporary side effects after just day case infusions of lutetium. And this was the co-primary endpoint, the best PSA response rate according to PCWG 3 criteria. So what that means is we're looking to see how many men get a greater than 50% reduction in their PSA. This is the classic waterfall plot. And bearing in mind how fast the PSA was rising in these men, this is quite remarkable. 2/3 of men had a greater than 50% drop in the PSA. So certainly signs of significant activity in this group of patients. And this is a snapshot of 8 of what we call our exceptional responders, 8 of the best men before and after lutetium treatment. So here's a guy, PSA 1,000, extensive disease. Here he is after 2 cycles of lutetium, completely free of disease. PSA is down to 7. Very similarly here, this patient of mine who used to walk with a frame on a morphine patch. After 4 cycles, his PSA has disappeared and his cancer has disappeared. He's off the walking frame and so on. And we got a lot of credit. This was the image of the year for the Society of Nuclear Medicine. So we have lots of exceptional responders. I won't go through those. We're showing you our best ones, but I will, point out that this was a temporary reprieve for almost all these patients because they do, of course, still go on and progress eventually. So this is the PSA progression-free survival, and the overall survival is only about 13 months. But, we'll show you that when compared with other 4th-line CRPC treatments, 13 months is actually very good for these patients. So there was enough signal in this study to be able to say in these heavily pretreated men, this has high response rates, well tolerated, with improvements in quality of life, which I didn't show you there, but it's in the Lancet Oncology paper. Hence, we needed to go on and say, let's see how it compares with, for example, cabazitaxel if we bring it forward. Before I show you the cabazitaxel data, I'll make a point about our use of FDG PET as well as PSMA PET. So you might think just do a PSMA PET. If it lights up, surely the lutetium will treat these patients. But because these are very heavily pretreated patients, we like to do FDG PETs on them as well, because here, for example, is a patient who was referred in for this study. We've published all this separately. High SUV max, you might say, yep, he's suitable for the trial. But if you do an FDG PET in the same patient, you see something different. So now we see quite high volume liver metastases here. And so this means that disease is not going to get the lutetium. So we deliberately excluded patients who have discordant disease. That's what we call this. Unless you can target everything, we said there's no point. So we exclude patients with FDG discordant disease. And we published this separately. And we showed that when we excluded these patients, the survival is terrible. The median survival is only 2 months for those type of patients. And so we think it's futile offering them treatment, and that's still our position. So we have gone on, once we started seeing early results of that, we went and designed a prospective randomized trial of lutetium versus cabazitaxel. And this is called the therapy study. That's what you see here in front of you. Again, another multi-site study based on the ProPSMA network, really. And we were randomizing men who had progressive CRPC post at least 2 cycles of treatment. In other words, kind of heading for cabazitaxel. And we randomized them to get cabazitaxel or lutetium PSMA. These slides are from our presentation at ASCO just a few months ago. And this paper will be submitted in December to a very big journal. So this is kind of interim data that we're showing here, but the full data will be revealed in a major manuscript in a couple of months' time, hopefully. I won't go into it in great detail, but I said it's progressive mCRPC randomized to either getting 6 cycles of lutetium PSMA or cabazitaxel as a standard of care. This is what we had, 200 patients randomized. Again, we recruited this trial quickly and so on. The FDG PETs were still essential for these patients. So here are examples of patients who we excluded. And that was, about 80 patients of the 300 and so who came along. So if you have not much PSMA avid disease, but lots of FDG disease, no point. If you're PSMA positive, but you also have separate FDG positive disease, we don't want to treat those patients either. Our primary endpoint was not powered for survival. It was powered for PSA response with secondary endpoints, and that's what we'll show you now, with secondary endpoints including radiographic PFS. By and large, unwell group of mCRPC patients. And here's the endpoint we presented at ASCO. So we see a 66% PSA, greater than 50% PSA drop in the lutetium PSMA arm versus 37% in the cabazitaxel arm. So this easily meets that primary endpoint, showing much better PSA response with lutetium PSMA. But of course, we need to wait and see, does that translate into better radiographic progression-free survival and better overall survival? But I think you'll agree, in a randomized trial, the early signs are very encouraging. Well tolerated, just as we'd expected, because it's very well tolerated when we gave it to men who had even more advanced disease. Strengths: first prospective randomized trial in the world of this treatment. A very active control arm. So cabazitaxel is certainly an active agent. We weren't just comparing it with placebo, and we believe that using FDG PET is still very important for these patients. So early data shown at ASCO in the plenary session by Michael and got lots of headlines, and we will hopefully be showing you the mature data in a few months' time. So finally, looking to where all of this is going, because we've shown you what happens when we give this to very advanced fellows who are about to die, and it looks very encouraging with a good publication there. We've shown you that the randomized data for progressive CRPC looks very encouraging. Let's see, do we get metastasis benefit and overall survival benefit? So what if you keep bringing it forward and forward towards us as urologists and the sort of patients we look after? So we've written a little bit about this in the past year or so in European Urology. We put up this graph showing where all this is going. This is that sort of familiar graph of the prostate cancer journey. This was our Lancet Oncology group, fourth line end stage CRPC, that's already published. This is therapy trial, which is, we've just shown you that data. There is another randomized trial in the US called Vision, which is comparing lutetium with just standard of care. So it's not an active agent like cabazitaxel, but this is set up for FDA approval in the US. And we've been waiting. That trial was supposed to read out at ASCO. It didn't read out at ESMO, and we're not sure will it read out at ASCO GU. Our sense is that it probably won't read out until ASCO next year, but hopefully it will be a positive endpoint. And then these are other trials in CRPC, like lutetium combined with things like pembrolizumab or olaparib, and these are 2 trials that we have open at Peter Mac. But these are the 2 I want to show you finally in finishing. What about if you bring lutetium PSMA right forward to patients with de novo metastatic hormone-sensitive prostate cancer with an impressive PET scan? Or what about even here before surgery for high-risk men? Could you do neoadjuvant lutetium PSMA? So these are 2 exciting areas that we've recently opened trials in. These are the trials we've currently had going. Pro-PSMA is in extended follow-up. Therapy is about to publish. These are the 2 of the combined trials with olaparib and nivolumab. These are based at Peter Mac. And these are the 2 trials I want to show you. That's just a schema. We do have a lot of funding for these trials at Peter Mac, and we recently opened a center of excellence called ProsTIC, which will turbocharge a bunch of more trials. This is funded by the PCF from the US, who gave us a very large amount of money to develop this center of excellence to do a lot of other new work. But I want to briefly show you these 2 trials that we recently opened. One is called Upfront PSMA. That's the one for the newly diagnosed metastatic hormone sensitives, a randomized trial. And the other one is LUTectomy, a neoadjuvant study. So this is Upfront PSMA. So this is newly diagnosed high volume metastatic prostate cancer. So men have to have, the classic sort of charted type of appearance with high volume PSMA avid disease. And these men who traditional standard of care for us would be ADT plus docetaxel, which is the control arm here, or they will have ADT plus 2 cycles of lutetium, then docetaxel. So we're adding in the lutetium as a boost to ADT and docetaxel. And this trial opened about 3 months ago in the middle of the pandemic, and thankfully is recruiting well. We've opened it at Peter Mac where it's based, and it's now expanding into the other 10 sites that we usually work with. So I think we have 4 sites open, even with the pandemic ongoing. So that's interesting. First line lutetium PSMA running. And then the last one I want to show you is for the surgeons in the audience like me who are interested in this area. This trial is called LUTectomy, a bit of a play on prostatectomy. So we're giving lutetium prior to surgery in high-risk patients. So the grant we got to fund this particular trial was based on what we saw in some of these very metastatic patients. So this guy had loads of bone metastases, and he still had his prostate there because he presented with it. And he was on the phase 2 study. So this is what we saw in his prostate, when he was having treatment for all his metastatic disease. And we could measure that on our dosimetry that he's getting a big dose of radiation into that prostate. And look what happens, once he's had a few cycles. His prostate responds very well, and his PSA responds very well. So we thought, will this work for de novo men with high-risk disease? So this trial is a neoadjuvant, really phase 1/2 trial, where we have men with high-risk localized or indeed node-positive prostate cancer who are being scheduled for a prostatectomy and lymph node dissection. And we're giving them either 1 or 2 cycles of lutetium PSMA 6 weeks before, and then go on and do the prostatectomy. And our primary endpoint is really to see what dose we can get in. We're really interested to see, can we get a high dose in here? So we're being realistic. I'm not sure will we show that they get a complete pathological response, although we're measuring that as well, of course. But if this is well tolerated and we get a big dose in, we'll expand it. Michael even wants this to be monotherapy, put me out of business. And that's the study schema for this one. We just published this trial protocol in European Urology Focus. And we've recruited in 5 men. I just did the first prostatectomy on the first guy about 4 weeks ago, and I've got the second one next week, actually. So a question for us was, well, if the guy has a big dose of lutetium into this big lump of cancer, is the surgery going to be more difficult? But pleasingly, it wasn't. He had a very straightforward robotic prostatectomy. This was not like doing salvage prostatectomy. So I think it's not going to compromise the surgery, and we'll just have to wait and see how the results go. So yes, all of this is very exciting. Clearly, PET imaging is exciting, and PSMA itself now is offering these theranostic possibilities, and we're excited to be involved in quite a lot of this work along the way. And my message to you all is really to get friendly with your nuclear medicine physicians. This type of work is only possible by having good relationships with people like Michael and his colleagues. Agus and others will recognize our MDT at Peter Mac, where we meet every Thursday morning to discuss all these cases. And the reason I show this, and we wrote this paper in BJOI last year, is to emphasize that nuclear medicine, they've become embedded in our prostate cancer MDT. And this happened about 5 or 6 years ago when we first got interested in PSMA, and they started coming into our meeting. And that's where we end up designing these trials and having the great ideas to put it together. So I say this to all of you: you don't have to, have a fancy setup like this. You just need to get friendly with your nuclear medicine physicians. And there's Hoffman, and it shouldn't be difficult, because, even if you don't work closely with them already, they're reading about this in their literature and watching webinars about it as well. Michael's actually doing a webinar tonight to Southeast Asia for a nuclear medicine group as well. So they are interested. And if you knock on their door and say, hello, I'm the prostate cancer person, I've got loads of prostate. Oh, they'll say, yes, come. We want to talk to you. We want to work with you. We want to see, can we develop a PSMA program in our region or in our facility? So I encourage you to go and make friends with your nuclear medicine physicians and see what you can make of it. Thank you very much for the attention.
Thank you, Professor Declan. Very nice talk. And I still missed one slide that you're not showing how many PSMA diagnostic center in Melbourne, because it's very compacted. In Indonesia, we still have one. I think there are a lot of questions. I think we are going to have a discussion later after the third speaker. So the next one is Dr. Jeremy Theo. we give a talk about the impact of social media in urology oncology services. Dr. Jeremy Matteo is the assistant professor of the Chinese University of the Hong Kong. He's the founder of Uro-Somi, or Urology Social Media, and he's very active in Twitter. I don't know, in other social media. Because of that, he also actually now is one of the social media editors in SIU Journal, the new journal, SIU Journal. So we are happy that Dr. Jeremy is already online. So Dr. Jeremy, please, the time is yours.
All right, so thank you very much, Dr. Rizal, for the kind introduction. Thank you, Declan, as well. It's a really, really amazing talk, really impressive, and I have loads of questions to ask you after my talk. All right, so I'll just talk about the impact of social media in uro-oncology services. And the word impact is very broad, but basically what I interpret is that it might help our clinical practice. It might change the way that we do things. And I think social media is really not just about having fun, but if you use it appropriately, certainly there are many ways that we can incorporate it into our clinical practice. And the first part of my talk is more general about social media, but in the second part, I will really talk about some examples on how we can use social media to help us understand the uro-oncology field and how it can actually help our patients by using social media. All right, so social media is actually quite a broad term, and basically any use of computer technology or media platforms that can allow people to share information or allow people to interact, social interactions. Basically can be defined as a social media. And so it's really broad, from Facebook to Twitter, or even a website blog, or even for a messenger type of platform like WhatsApp or Zoom, what we're using right now, can, to a certain extent, we can interpret it as a social media platform. So given it's such a broad term, basically we can't really live without social media in this modern era. But of course, there are so many different types of social media platforms. And I think especially when you are trying to incorporate the use of social media in your practice, you really need to understand how the situation is in your locality. And you really need to know about your target audience. Who are you really trying to target? And so, of course, Facebook has the largest number of active users, although the number is slightly dropping in recent years, but then it's still the biggest platform, still very commonly used in Hong Kong. But then there are many other different types of platform that has gained a lot of interest. YouTube, definitely, Instagram, Twitter, etc., etc. And I think it's just, that they differ in terms of their style. For example, Instagram is mostly photos, Twitter is mostly like a short messages, like a post-it type of thing. So it really depends on what you are trying to bring to your audience, and you select the best platform. But I think for the medical field, among all the different types of social media platforms, Twitter does seem to be the preferred one. At least it allows a lot of different interactions between healthcare professionals. There's just an article published 3 years ago saying that Twitter is trending in academic medicine. In fact, what they did is a survey about the Twitter users, and they realized that there are lots of academic faculty or professional staff, researcher who are using Twitter. So it seems that this platform, the users using Twitter, they are the right audience to communicate with in terms of academic knowledge, in terms of the dissemination of medical information. But of course, bearing in mind that there can be other types of audience as well, general public or journalists. So it doesn't mean that we can just show a picture, whatever picture we want, or show a body part image. Of course, we need to be very careful as well. But the majority of the Twitter users are actually within our field, and it seems to be the right audience. And interestingly, The number of Twitter mentions, the degree of engagement, although, you know, it depends on how interesting that you're sharing, and it depends on how active you are as well. But then, interestingly, people, if you do well in social media in terms of engagement, people usually interpret you as a kind of a key opinion leader in a certain aspect. And even a Twitter mention can be considered as an indicator for measuring research impact. And certainly, many people believe that Twitter can change the way one read and spread scientific knowledge, etc. So it seems that people do acknowledge Twitter as a good platform for exchanging scientific information. And of course, apart from sharing medical knowledge, you can also, you know, have a lot of different sharing of fun things or fun facts that you see. And these are just some examples of Brian, Olivia showing hearts of stone, hearts of blood. And interestingly, Declan also showed MRI scan of himself or a prostate gland. I hope he doesn't mind. But then, you know, practice what you preach is really a very nice tweet. And it's, you know, everybody is, I find it very fun looking at this image. And what I'm saying that, you know, it's a good platform for sharing of your personal experience, apart from sharing medical knowledge. Is also a good platform. But I always think, you know, social media is fun, but how we can really maximize the utility of urology social media in the dissemination of medical knowledge, in teaching, in education, and ultimately, can we really benefit our patients by incorporating social media in our practice? And therefore, about 2 years ago, I started using this hashtag Urosomi, urology social media, trying to gather a group of people. And we started with a lot of case discussions, really trying to raise some interest, trying to, you know, discuss about difficult cases, how we're going to manage it. And hopefully, you know, everybody can benefit among the discussions. And this is just a diagram to show you social media can really disseminate very efficiently. And basically what this showed is that within a week time, we are able to engage over hundreds and thousands of people engage in our academic discussions using the hashtag as well. I'm just trying to show this figure to show that you can really reach so-called a viral type of effect if you use social media in an appropriate manner. And of course, thanks to BJI, the hashtag was able to get an innovation award. And of course, you make a lot of friends as well. But back to our topic, Uro-Oncology services. What can Urosomi offer? And I really tried to look into the past few months, what has social media really helped us in understanding Uro-Oncology in particular. And the first thing that I think social media can really help us is when we need something very urgent. For example, at the beginning of the COVID situation, of course, you know, the viral infection is very scary, and I'm sure many places in the world has been experiencing a lot of disruption in terms of clinical services. And during that time, our group has decided to do a survey, and we utilized the social media platform to help disseminate the survey. I must say, surveys conventionally should be done, you know, via society, association, via registered email addresses, etc., etc. And surveys done using social media platforms are not considered to be something totally appropriate in terms of methodology. But certainly the use of social media is able to help us reach as many people as possible within a short period of time. And certainly there are ways to optimize the methodology, but I won't go too much on this. But basically, I think during that time, given the impact of COVID-19, we want to have urgent data on this. I think it's something very reasonable to do. And so we decided to do a survey, global survey on the impact of COVID-19 on urological services. And just within 9 days time, we were able to gather a total of 1,004 survey responses. And this is just to show, even within 9 days' time, the total number of COVID cases raised from 800,000 cases to 1.4 million cases during that time. So it's really conducted during the surge of the COVID-19 cases, and having it done within a very limited, a very short time period is very something very useful. And so in this survey, basically we want to look into the degree of reduction in urological surfaces, and we certify it by the location, by the degree of outbreak, and also by the nature and urgency of urological conditions. So this is just a global map showing the cut down of outpatient clinics globally. So we understand which area is actually being affected the most. And we're able to show that the degree of disruption in terms of urological surgeries actually increases with the degree of outbreak. And this is also kind of expected, but you realize that the cut down of urological surgeries can be a lot, like more than 80% in the countries which were seriously affected by COVID-19. And of course, we can also look into the type and nature of the conditions, and fortunately, cancer cases are less disrupted because cancer cases are usually considered to be more urgent. But still, some types of cancer, for example, prostate cancer in particular, are still being affected. And in terms of clinics, in terms of procedures like biopsy, in terms of cancer surgery, we realize how much COVID-19 has really affected in terms of the provision of healthcare delivery, and realize that many patients actually had delay of the healthcare delivery, and more than 30% had delay of more than 8 weeks. Of course, if it's just a benign conditions, it might not be very, affecting the survival. But in terms of cancer surgery, then it really might affect the survival. So I think it is the use of social media in terms of survey dissemination. Sometimes it really can help. But of course, I think this should not be used in every scenario, because everybody is experiencing survey fatigue right now. But in the appropriate time, when it is needed, survey via social media can be very helpful. And the second thing that I think social media does help is about sourcing of data. Many of you would have heard about Burst Urology. I think they have been extremely successful in using social media in trying to recruit centers globally and trying to collect data, prospective observational data globally. And it has been run for a few years, and basically every year they had at least one project on a specific urologic condition. And just using this as an example, back in 2017, they started the Identify study, basically trying to look into the diagnostic pathway of hematuria and urological cancer. And this is one of the first tweets that they've made back in November 2017, and just within 1.5 years, well, less than 1.5 year time, they successfully engaged more than 100 centers, and they collected data from 110,000 patients. And so I think this is probably one of the most successful examples on how you can try to engage interested parties to work together. Of course, there's some prerequisite. You need to have maybe a relatively simple project, prospective observational study type of design, then it's easier to engage centers, and it's easier to ensure that the data being collected is of high quality. There are some prerequisites to make it successful, but certainly Burst Urology is one of the most successful examples, and they are able to come up with a really nice data in terms of the optimization of the diagnostic pathway for hematuria. And in terms of cancer, COVID surge is, again, a very nice example, very much similar to Burst Urology, but they had a special focus in the outcomes of cancer surgery, particularly during the COVID pandemic. Again, simple design, prospective observational study with or without COVID infection, and then they look into the cancer surgery outcome. And basically, the COVID-19, it really, globally, it really started to, the number of cases really started to rise starting from February, March. And then they already quickly set up the website, quickly launched the study. And this is just one of the publications that they have published. And they basically reported the data up to April. So within 1 or 2 months' time, they are already able to come up with a lot of data, incorporating 10 solid cancer types. And they try to look into the comparison between the so-called COVID-19 free surgical pathway versus no defined pathway, and they look into the outcomes, namely the 30-day postoperative pulmonary complications, as well as the post-COVID infection rate. Basically, they try to collect data from the centers. They try to define whether your center has a COVID-19 free surgical pathway, meaning that you have separate wards, separate operating theaters, separate ICU support for patients with COVID-19. So patients with COVID-19 and patients without COVID-19 are completely separated in terms of the clinical management pathway. And if your center didn't have such a separation, then it's so-called no predefined type of pathways. And basically within 1 or 2 months' time, they were able to gather more than 9,000 patients' data from more than 400 hospitals, and 2,400 of them were in the COVID-19 free surgical pathways. And they realized that such a logistic type of management was able to reduce the rate of pulmonary complications from 4.9% to 2.2%, which is quite a lot of reduction in terms of the relative risk reduction. And the post-operative COVID-19 infection rate also reduced from 3.6% to 2.1%. I think this is a very nice example showing that if you utilize social media nicely, if you have a good design, certainly you can have a lot of data within a short period of time, and you'll be able to provide some insightful data which will be useful in our future management as well. And the third thing, which I think is something very interesting, is social media analytics. Basically, it is a practice of gathering and analyzing data from social media platforms. There are so many softwares that allow easy data extraction. Basically, using Twitter as example, each tweet can be converted into an Excel format, what we call an API data. And there are so many softwares that can extract these raw data from the social media platforms. And therefore, you can analyze a lot of things and try to understand what is the best. For example, how you can engage your audience successfully. You can actually do a lot of analysis. And you're interested, we do have an article explaining this. And this is just an example of what we did last year. Basically, we tried to gather tweets which contained the hashtags EAU19 or EAU 2019. And we tried to look into the different parameters, namely the word count, number of mentions, hashtags, number of followers, etc., etc. And we tried to look into the outcomes, number of likes and number of retweets. We realized that a so-called successful tweet has a certain characteristic. For example, if you have more information in your tweet, if you have a photo in your tweet, if you have more mentions in your tweet, then you tend to have more likes and more retweets. On the other hand, if you contain too many hashtags, people may get confused, and actually the degree of engagement may not be as good. So this is just an example how social media analytics can help us understand in terms of social media marketing in particular. And this is just another example, Google Trend. If you type in Google Trend, you'll be able to find a very nice website, and you can actually key in some keywords. For example, here, I have tried to search for prostate cancer, bladder cancer, and kidney cancer. Basically, they try to look into the search history of everybody worldwide. say how frequent people searched about prostate cancer or bladder cancer or kidney cancer. And very quickly, you'll be able to come up with a graph as shown here. Basically, it shows how the public interest is based on the terms of your search. So obviously, prostate cancer in blue here has the greatest amount of interest globally. And this is in terms of what we call a relative search volume. So when I keyed in these three terms, the number that I get is relative to each other. So prostate cancer relative to bladder cancer and kidney cancer, prostate cancer has the greatest amount of public interest. And this is just a very infographic type of graph, but actually you can also export it into Excel file, and then you can perform so many types of analysis. And this is just an example published in European Uro-Oncology, consulting doctors Google for prostate cancer treatment options. Basically, they try to look into public interest in the different types of prostate cancer treatment in terms of surgery, radiotherapy, focal therapy, etc., etc. And basically, you will be able to use the raw data every single day and try to plot out different graphs. And here is a scatter plot. And basically, the authors try to use the joint point regression analysis and try to work out the trend of public interest. So if you look into the top left corner one, it's prostatectomy versus active surveillance. So initially prostatectomy has so much interest, but then eventually it dropped and active surveillance has gained a lot of interest. So, you know, using social media analytics, we can really understand a lot more, not only in terms of healthcare professional knowledge, but also in terms of the patient's interest, public interest in a certain treatment. So it depends on what you want to look for. But in this case, I find it very, very interesting. And of course, one thing that has really changed is the way that we see and manage our patients. And obviously, especially during the outbreak of COVID-19, everybody is worried about infection. And in Hong Kong, for example, it's having a default rate of 30% is like a norm. Now it's resumed normal, but during the outbreak, basically everybody is afraid of even going to hospital to see a doctor. So telemedicine definitely has gained a lot of interest. And in fact, we also did a survey, and we had the responses from 620 urologists, and we found that when we compare between pre and post COVID-19 time period, for those without telemedicine experience at all, they really had an increasing interest of using telemedicine because of need. And it increased from 43% to 80%, which is quite a lot. And the actual utility of telemedicine increased from 16% to 41%. And most of the doctors actually, after trying out using telemedicine, they are interested in continuing telemedicine in their clinical practice, even beyond the COVID-19 period. So certainly telemedicine has gained a lot of interest. It may continue even after COVID-19 has settled. And if you look into European Urology, there's a very nice article stating some important points, some suggestions and recommendations on the use of telemedicine. And basically, it is very useful in terms of reducing the frequency of face-to-face type of consultation, therefore reducing the risk of infection and hopefully reducing the amount of resources being wasted as well. And this is a very nice paper summarizing the things that you need to consider, the types of technology tools that you can use, and different aspects, for example, in terms of scheduling of patients, in terms of televisits, in terms of handling examinations or drug prescriptions or follow-up of the patients, how you should manage these patients in the telemedicine era. This is a very nice article, so if you're interested, then feel free to have a look. And basically, in brief, you need to define the target audience. I would say not every patient is suitable for telemedicine, but there are certainly some, for example, low risk prostate cancer follow-up, BPH, especially when physical examination may not be absolutely crucial. mostly just ask about the symptoms, or maybe you look into lab results, then these are the best case in practicing telemedicine. Certainly, it's not easy to set up something from zero. So you need to have a very enthusiastic and motivated personnel who is interested in doing this, who is interested to get trained in doing a proper telemedicine visit. And you need to have an implementation timeline. You need to have the necessary equipment in terms of computer technology, for example. Not only you need to make sure that it's available in your clinic, but you need to make sure that your patient actually has the necessary software in making it happen. So there are many things that you need to consider in order to make it happen. And certainly, although it's very good in terms of reducing face-to-face type of contact, but we need to be careful as well, because there can be some traps or some easily committed mistakes that we need to be careful about. For example, if you want to communicate really sensitive information, then maybe a face-to-face type of visit is better. Or if you want to have some type of consenting procedure, then again, it depends on it may not be the best platform to do it. So again, I encourage you to read the article if you're interested in setting up telemedicine in your clinical practice. Certainly, social media is something that is very useful. Certainly, it might reach a very fast and efficient type of dissemination, like a viral type of effect. I'm just trying to show you, for example, in this tweet, I tried to talk about a recent paper that I've published, and you can see that the degree of impression is more than 14,000, and the degree of engagement more than 1,400. It's quite a lot. But I want to stress and emphasize that we need to be extremely careful in using social media. Although the majority of audience is still healthcare professionals, but then there are general publics, there are laymen, and you need to be extremely careful, and you need to make sure that you use it appropriately. And again, EAU has a very nice recommendation on so-called appropriate use of social media, especially in terms of patient privacy. We need to be extremely careful to respect our patient privacy. And there are many other things, but again, if you're interested, feel free to have a look. But one thing that I want to highlight is that there are a lot of misinformation in social media. And this is one of the very important papers by Stacy, looking into the dissemination of misinformative and biased information about prostate cancer on YouTube. Basically, what they found is that videos that has the greatest amount of engagement, greatest number of views, generally has a very poor quality of information. And those videos which are considered high quality in terms of scientific value, generally they don't yield a lot of interest. So this is something very alarming. But being a healthcare professional, we should really try our best to safeguard the appropriate use of social media, safeguard the accuracy of the scientific information they want to disseminate. Certainly a very useful tool, but we need to use it in a proper manner. So in summary, I think social media definitely has a huge impact in uro-oncology services in a number of ways, be it a sharing of experience, be it collaborative research work, telemedicine, et cetera. And I think in this modern era, we can't really live without social media. You can try to escape from it, so-called having a vacation, but then it's really difficult to escape from it totally. And it's certainly the utility of social media is likely to increase in this era. So I would encourage you to try it out, and it's never too late to start. So start engaging yourself with social media, and hopefully when you encounter appropriate situations, you can use this social media wisely and in a proper manner. Then hopefully you can reach what you want to achieve within a short time period. And by this, I would like to thank Rizal again and the organizing committee again for the kind introduction, for the kind invitation. And if you have any question, I would be very happy to answer them. Thank you very much.
Thank you, Dr. Jeremy. Personally, that actually I learned from him how to use the social media, and I had a lot of nice experience, also collaborative, new things, new knowledge. It's good, I hope, because I saw also the participant is, I think more than half that they are younger urologists or residents. So of course they are more familiar with the internet and using the social media. Now we move to the discussion. There are already some questions. First, there are 2 questions for Professor Declan, and then 1 question for Dr. Jeremy. For Professor Declan, what do you think about the cost effectiveness? Because you said you believe that the cost effective of a PSMA PET scan compared to the conventional imaging. Is it true that the PET-CT scan is more cost efficient, especially for the high risk prostate cancer?
Yes, so this was a pre-planned analysis. We've done a health economic analysis of pro-PSMA, and it's actually being presented this week at the EANM, the European Association of Nuclear Medicine meeting, by our health economists. And the paper is almost finished in European Urology. It's in its 3rd review. So I think the full paper about the health economic analysis of PET imaging will be in European Urology within a few weeks. It's just in its very final stage. And look, so that was very encouraging. A pre-planned analysis showed that it was very, I can't tell you the full day, it was very cost effective. But the caveat is that it's very, very different from one country to another country. You know, PET imaging can get very caught up in regulatory problems. So in Japan, for example, it's almost impossible to do PET imaging because you're not allowed to transport radiopharmaceuticals on the road. So the only way you can do a PET scan in Japan is if you have a cyclotron in your hospital. So this would make this ridiculously expensive, for example. And likewise, there can be some regulatory hurdles in some countries that mean it's very expensive to do the preparation of the ligand. So in providing any health economic analysis, it's only based on what we have in Australia. And many other countries can be like that, like India, for example. And if you have a favorable regulatory and logistic framework, in other words, you don't have huge expenses like they have in Japan because of the regulations, then our analysis shows that it's very cost effective. So, you know, in Australia, in Australian dollars, I'll give it to you in US dollars, the cost of having a CT scan and a PET and a bone scan, so conventional imaging, is about $800 US dollars. That's roughly what it costs the health system. And a PSMA PET CT costs $700 US dollars, so it's cheaper. It's one visit to the hospital. It's less radiation, less equivocal findings. So it's cheaper for us to do it. But we have a lot of PET cameras, as you said, August. You know, in Melbourne, 5 or 6 million people, we have about 20 PET CT systems, including 5 at Peter Mac alone. So we have, you know, if you already have PET systems, then for us, it's very cheap to do PET imaging. But look, my hope is that as this type of data gets out there, people will understand that conventional imaging for high-risk patients is a problem. We fail our patients all the time because of the poor accuracy, equivocal findings, you know, excessive radiation, and so on. And I think we should try and push hard to for our regulators and so on to say, well, PET imaging is really an important cancer imaging tool for FDG, for example, for melanomas and rectal cancers and so on. But for prostate cancer, we've shown that it's very feasible and very it meets all the primary endpoints and secondary endpoints. So we should be pushing hard to say, let's do this for our patients. Because
yeah, I hope there was a nuclear medicine here join us also. I hope they hear it. I mean, in Indonesia they can reduce the price, so it's better for the services for the patient. I know Professor Declan is not the nuclear medicine, you're a urologist, but there is a question about, is there any differences between gallium and F fluorine 18? Because in Indonesia we have one, but they based on F18 PSMA for PET scan. And then the next question is it possible that it continue to the theranostic or with lutetium 177 PSMA. Do you have any comment on that?
So on the first question, yes. So there are now 5 or 6 different PSMA ligands available, and PSMA 11, or gallium PSMA as it's called, is the one that really made all the waves a few years ago because it's very cheap. You know, the formula is available on the internet. There's no intellectual property. So if you have a gallium generator in your nuclear medicine department, which people often do for neuroendocrine tumors, you can label it just with a you know, radiopharmacy people can do this. So that's the one that most data is on. And we've published a really big systematic review, 5,000 patients in European urology, and about 2/3 is on that. So, and that's why we used it for ProPSMA. But in our center, we have used 4 different PSMA tracers. And my summary for you is that any of these are very good. Whatever you can access, if you can access a small molecule ligand in your hospital, whether it's gallium PSMA or DCF PYL, which is the one that came out of Johns Hopkins, and that one will get FDA approved next year in the US, or F18 1007, or the other one we did first in man was THP PSMA. They're all very, very good, and so I wouldn't split hairs about them. We have a non-inferiority trial comparing DCF PYL with PSMA 11, and they look exactly the same. There are certain advantages in the fluorinated ones because they can be manufactured to GMP standards, good manufacturing practice standards, which means they're easier to commercialize. So if you have a fluorinated PSMA, you can make it in a cyclotron and then ship it all around your region like you would do with FDG. Whereas gallium, you need to have a generator on site and so on. So I think the future is probably the fluorinated tracers because of the fact you can mass produce them to a higher level. But I caution that the problem with that is most of these fluorinated tracers are commercial tracers. So DCF PYL is an American thing, you know, so if they get that FDA approved, guess what? It's going to cost $5,000 US for a dose of it. Whereas the gallium, you can still, you know, download it from the internet and get your radiopharmacist to tweak it up. It's not quite as simple as that, but it's pretty close. So they're all about the same, Agus. That's my main message to you. And if you can get your hands on any of them, they're all very, very good. And also, by the way, the PSMA 11, the one we did for ProPSMA, will almost certainly get FDA approval in December at the December meeting based on a academic trial led out of UCSF. And in fact, I'm doing a talk at PCF at ASCO GU in February. And the title they've given me is, what will the approval of PSMA mean for decision making? And I said, oh, has it been approved? And no, but we now see it will get approved. So like everything, you know, the Americans, excuse our American colleagues, will ridicule everything that they don't have access to, as they've done for years and years with PSMA. And then as soon as they have it, it'll be they invented it. But it does help because if huge amounts of data and trials will be based on PSMA because everyone in the US will have it next year, it might help us everywhere else as well. But I caution again, part of the beauty of this is it has been relatively cheap because there hasn't been an IP on it. And that's what we have to try and keep here in the Asia Pacific region. You know, we're not going to be paying $5,000 for just a PET scan. Because the Americans are going to insist that that's what they charge. So, and that's actually, that's the one thing I've learned about nuclear medicine. I hope our colleague is still on the line. They're wonderful at tinkering and fiddling with these peptides, and radiopharmacists, radiochemists are very clever. And I've now been to a few nuclear medicine conferences, and it's not like going into a urology conference hall where there's the Ipsen stand and a Stellis, and then there's a robot and some endourology kit. You know, there are miniature cyclotrons and miniature PSMA PET generators. And then there's all these walls of peptides for all these radiopharmacists to say, oh, this is how you tweak this and tweak that and label this and label that. And I have great admiration for the nuclear medicine industry, I must say. And I think that they're very quick at reinventing PSMA. So the second question was about Theranostics and PSMA. So again, we've been able to do that because it has been relatively cheap. We've been using lutetium PSMA 617. So that's the ligand we use to bind the lutetium to. And that was, you know, put together by a small company in Germany called ABX. Again, clever little Germans with their peptides. And then they sold that to a US company called Endocyte for about $10 million about 5 years ago. And then 3 months after we published our trial in Lancet Oncology, Endocyte was acquired by Novartis for $2.3 billion US because of this, because of a 50-person study. So this, again, I worry about that because they've looked at this and said, right, lutetium is going to go all over metastatic prostate cancer and we're going to commercialize it and make a fortune out of it. But guess what? You know, within a few months of that happening, again, the Germans had created 2 or 3 different versions of PSMA that you can also attach a lutetium molecule to. So now we have PSMA INT, which we've just written an editorial for in European Urology. And there's another one about to come into the market as well. So I have great confidence that the nuclear medicine industry will keep providing affordable solutions for both the imaging side of it and also for theranostic partners.
Okay, thank you. The next question for Dr. Jeremy. We know that usually in the past, social media we are using it for pleasure, showing our picture going somewhere, but now it's become more academic or more scientific way. Will be another stress for us using a social media because we are going to be more scientific? And the second is, how do you manage the time for doing this social media or manage your social media?
Well, at least for me, I never interpret it as a type of stress. If you're really, really fed up, you can have a vacation. You can uninstall your Twitter, for example, for a while. But I think it is a really good way, and in fact, it's a pleasure generally to have a lot of different types of discussion and interactions with urologists globally. And you realize that healthcare practices can be different, can be very different across different regions. So I personally find it interesting, and I never interpret it as a type of stress. And in fact, I would encourage you all to, if you haven't tried it before, you can try it out and see whether you like it. And if you don't like it, that's fine, totally fine. So if you don't like it, never mind. And if it is stressful, just don't do it. So I don't think it's a big matter generally.
Okay. I saw your has succeeded published a survey using a social media. Do you have any, there is a question, is there any tips or trick, or is it the same way when we do the study or research?
Well, actually, surveys disseminated via social media platform is not the most conventional way of doing it. And it's going to be challenged by reviewers. And the main challenge is about the sampling part, whether you sample the right audience. And so this part, you really need to try your best to make sure that the responders are the right ones, or you can kind of prove it because there are different types of softwares in which you can work out the social network that you have reached. The graph that I've showed you, you can see actually who are the people that you have reached out. So, if you really experience a tough review, then you can try to analyze that part just to prove that you have reached the correct audience. And there are many ways to try to optimize the methodology as well. For example, you can try to limit the IP address, for example, just to make sure that there's no duplication of the responses. Of course, as in other surveys, you can do it very properly with a Delphi type of development process. And I think generally it's more or less similar, but there are some tips trying to optimize the methodology. And I'm glad that most journals are still accepting surveys that has been conducting via the social media platforms.
Okay. Yeah. So, yeah. You text me that you want to ask personally to Professor Declan, so please.
So I want to take this opportunity to congratulate you and your team. I mean, it's really amazing results, and it's really impressive to see that there are so many ongoing trials. It's crazy. And congratulations for that. I have two questions. You mentioned about the potential disconcordance between PSMA and also the usual FDG type of PET scan. And also, of course, we realized that some prostate cancers, they may not be PSMA fit. So my first question is, for primary diagnosis, of course, we trust our PSMA results, but then when will you start to suspect that it might not be accurate? And this is the first question for primary diagnosis. And the second question is, when we consider doing theranostic, so it seems that we should really perform both PSMA and also FDG PET scan. So is this something that you recommend? And when you say so-called disconcordant results, say for example, if it lights up on PSMA and it doesn't light up on FDG, is this considered a so-called disconcordant result?
Very good. So on the first one, when are we suspicious? Because you know, we're all great believers in PSMA, but we've all seen when it lets us down. We've shown that the specificity is very, very high, Jeremy, and not just us, but others. In our big systematic review, we showed, you know, the specificity is about 95%. So what that means is if something lights up with a high SUV, it's almost always prostate cancer. So that's one of the big attractions. The sensitivity is a different issue. So if you think of primary staging, when are we suspicious? Well, you know, if you know you've done a biopsy and you've got a high grade nasty prostate cancer, you know, high volume, etc., and there's really almost no avidity in the primary, then you've got to be suspicious that it's one of the about 5% of prostate cancers we saw prospectively that don't express PSMA, because they're there. And it's not always low grade, it's sometimes high grade, but about 5% of prostate cancers primary without treat don't express PSMA, and therefore, you know, you won't see the small lymph nodes, but your conventional imaging will tell you so. So I think looking at the primary is very important, and it's very easy to go and stain the primary, do immunohistochemistry for PSMA. It's very cheap, so we always have PSMA available, and we do it a lot if there's any uncertainty. And then that flows into, I'll just mention biochemical recurrence, because that's where most data has been published. And you well know, you know, high volume surgeons like you, high risk prostate cancer, we see a lot of biochemical recurrence. And what we showed again in big systematic reviews is that the sensitivity for detecting disease for biochemical recurrence really varies as the PSA goes up. And at a PSA of 0.2, for example, about 25% of patients will have a positive scan, which is kind of amazing compared to conventional imaging, but it still means that, you know, a lot of patients, you won't see it. And then at 0.5, it's more than 50%. So PSA at 0.5, we're picking up 50-60% of patients will have a positive scan, and so on. And we published all these AUC curves for that. So what do you do then with the patient that's come back and maybe he's had 1 or 2 scans and now his PSA is 1.8 and he's still PET scan completely normal? You know, I think you've got to consider that, again, he may have had a primary that didn't express PSMA, but his surgery was 5 years ago and you didn't have a PET scan on him at the time. So that's the other one. You know, don't put all your money into, all your decision making into PSMA if it's something's out of kilter. I hope that's helpful. On the theranostic side and the discordant disease, yeah, you raise really good points, because we've taken a strong view that we think if you're going to do lutetium PSMA for a patient with metastatic disease, you should do an FDG as well as a PSMA. And we believed it because we did that for the phase 2 study, and we showed that those discordant disease in about 25% of patients, and we showed that they did really badly. So conceptually to us, we thought, look, this should be like precision medicine. It's like doing, you know, a somatic biopsy and trying to look for a DNA repair defect. And if you've got a BRCA2 defect, I'm going to offer you olaparib for your CRPC, you know, so it's a precision approach. You see a biomarker and you go for it. And we think PET imaging is like an imaging biomarker, except you don't have to have a biopsy. So if we're going to treat somebody with a therapy that's based on the PSMA being very active, so the lutetium will only go to where the PSMA is active, we think it makes sense to do that and not to treat patients who have got a lot of cancer that's not PSMA active. So we've taken that view, and it's in all our trials that we do both. But people have pushed back and said, and that's why our results are probably very good, because the retrospective series, not the prospective, we're prospective, the retrospective series from Germany, their PSA response rates are not as good as ours. And we believe it's because we're just selecting patients better. We're turning down the patients with low PSMA expression or discordant disease. But we think that makes sense. It's like a biomarker, you know. But on the other hand, the critics will say, well, you know, you may be doing a disservice to some of these poor fellows. You know, if they've got a lot of PSMA-avid disease, give them some lutetium and maybe they're going to get a big benefit. And yes, there may be progression in the other site, but you know, you may still help. And maybe that's the case. And in actual fact, at Weill Cornell in the US, they're even treating patients. They've got a protocol giving them lutetium PSMA without doing a PET scan. So they're not even looking. They just squeeze in the lutetium, and that's almost the total opposite of what we do. So you know, maybe there's somewhere in between that's right. But I you know, FDG for FDG PET, and we just like the idea that it helps selecting patients that are more likely to benefit. But I'm prepared to say maybe we're a bit too selective.
Just one more follow-up question, because I totally agree. Having a best patient selection is critical to ensure that the treatment response is going to be good. But for example, if the FDG doesn't light up, it may happen, right? But the PSMA lights up, so it's not really this concordant in that perspective, isn't it? So these patients might still respond to the treatment. Is that the right way to interpret it?
Yeah, for sure. So we see plenty of patients who've got both. They've got high volume bone metastases with high PSMA expression and high FDG expression. So that's not an unusual thing to see, and that's no problem. We'll treat that. And look, we have a little bit of a window where, say, they've got extensive bone metastases with lots of SUV activity, and maybe there's one bone metastasis that has really striking FDG activity. We will still probably treat those patients. But what we don't like doing is when you have quite extensive FDG-avid disease. And by the way, so we've biopsied these. This is a separate paper in preparation. So you'll have someone with a big mediastinal mass that has no PSMA expression, but high FDG expression. And then down in the abdomen, they've got extensive retroperitoneal disease. And they might have, you know, obstructed kidneys and bilateral nephrostomies. So that disease down there will recover, will respond well to lutetium PSMA. But this big thing that's causing the chest tightness won't respond. And so we've biopsied that particular patient of mine, and he's got extensive neuroendocrine differentiation in his mediastinal mass. And he's just got straightforward, you know, still got AR in his retroperitoneal mass. So that he needs a different approach. You know, he's going to need platinum-based chemo maybe to try and treat the neuroendocrine differentiation. And so that's for pathological correlation, that's the most typical example. Is you've got the big FDG-avid thing that's probably neuroendocrine differentiation, and you've still got heterogeneous disease elsewhere. And I think that's the nice thing about the imaging. It's avoiding a biopsy, but you get quite a good molecular signal for what's going on in the extent of his metastatic disease. And look, therefore, you can tell we're enthusiastic about nuclear medicine. I'm actually, you know, going to do a sabbatical in nuclear medicine in the next year or so, and take some time off and go and learn more about it, and learn more about radio-guided surgery using PSMA, and try and see what else we can come up with to drive the next 10 years of it. But it's a very interesting area, and the nuke meds like working with us, I believe. So as I said earlier, you know, reach out to them, knock on the door and say, oh, are you interested in prostate cancer? They'll say, yes, I've just been watching, you know, somebody from Melbourne talk about this, and they showed these lovely pictures. Do you have any prostate cancer patients? And you can say, yes, let's have a coffee.
Yes, I think that's also happens in our place. The nuclear medicine asking for the urologist, is there any patient? Then we start with the trial, some patient, and very nice picture for the PSMA PET scan. Actually, I saw one participant raise the hand. Is it there still wants to live question or not? Or just make a mistake, press the button? Okay, I think last question for Dr. Jeremy. You said it's never to be late using the social media. Do you have any suggestion how we start using this social media for the scientific reason?
Well, the ECA, you know, you don't have to take it extremely seriously at the beginning. So just install the apps, you know, have it for fun, see if you like it. And gradually, if you're a urologist, definitely you will encounter people exchanging knowledge or discussing about urology related scenarios, and you would have more experience in really discussing academic knowledge in the social media. But of course, it depends on your personality and your schedule as well. So you really need to try it out before you know whether it's something suitable for you.
Okay. There are two last questions for Professor Declan. The first one is, what do you think about the patient with decreasing renal function? Is it possible that we can get the PSMA PET scan, or giving the theranostic lutetium 177 PSMA?
No, so it is excreted through the kidneys. So if they've got severe renal failure, that's a contraindication for us.
Okay, I think the last question is actually, I remember last time when I visit you that you mentioned in Australia there's extremely changes for the urologists use the PSMA PET scan for the primary staging. That I get your impression that you also actually a little bit doubt about that. But and also the guidelines now is still not how to say it, recommended for the primary staging. There is also a question from the audience. Do you think now, after you get your result, do you suggest the PSMA PET scan as a urine stool is in the primary or initial staging?
Yes. So do you mean, for example, as we're
after biopsy, we do the staging with the PSMA PET scan?
Oh yeah. So look, that's what we very strongly believe, and you will see that in the guidelines in the next year. So Pro PSMA is within the time period for next year's EAU guidelines. So we'll be very interested to see what the EAU say about it. I think they are the best guidelines, but we missed it for this year. But actually, they flag it in the guidelines that Pro PSMA was pending. So I'm very interested to hear what EAU say about it. But, for that patient population, which is newly diagnosed high risk or unfavorable intermediate risk prostate cancer, that's what we show. The accuracy is better, and those secondary endpoints are all there. The skeptics will push back and say, well, you haven't shown that you improve the outcome of patients by just getting the better information. But of course, that would take 15 years to do that. There's an editorial just published in European Urology about Pro PSMA from some of our medical oncology and radiation oncology, just saying, well, be careful about making decisions based on a PET scan. Like, for example, that guy I showed you, 46-year-old with metastatic disease in the abdomen, conventional imaging is normal. What do you do with that? If he hadn't had a PET scan, he would just go straight for surgery, and he'd fail, of course, and maybe have pelvic radiotherapy, and then he'd fail that. But, maybe you help by taking out the primary. So that's a different research question, I suppose. But, I think that's why people push back a little bit to say, be careful about making decisions when you don't know, is that going to be the right thing for the patient? But that's not you can't design a trial for that based on this. That's a 15-year study. But I think that, if you believe that having more accurate information is important, then you should do a PSMA PET CT, or you should push for it in your guideline and see, can we afford it? And that's what we showed. It's certainly affordable. So that is what we do. We literally do what we showed in the trial. We do PSMA PET CT staging for every patient with high risk or unfavorable intermediate risk. If you've only got favorable intermediate risk, like a little bit of 3+4, 5% pattern 4, you don't really need any cross-sectional imaging. That's what the EAU guidelines say. Those patients have had an MRI scan before the biopsy. But for the higher risk ones, the ones where we show 27% greater accuracy, do a PET scan. That's my view. Yeah. When you mentioned primary staging, I think what you were also talking about, Agus, is we also have a trial running called the primary trial that I didn't mention, but primary is a trial before biopsy. So it's like the precision study or the promise study. The protocol, we published it in BJUI a few months ago. So this is to see, if you've got someone who's had an MRI scan and they're due to have a biopsy, transperineal, they all have to be transperineal for this trial. do you get any extra information if you also do a PSMA PET CT, but only a quick scan, only do the prostate. So it's only a 10-minute scan. That's what we're doing. And we do targeted biopsies of the MR lesion or the PSMA lesion or both or whatever. And it's a 350 patient study, which we've nearly fully recruited, which will see whether PSMA PET adds anything. And look, so for example, will it add anything to the PIRADS 3 lesion? Will it show something different? And another extension. I'm not saying that's where this might end up, but you never know. Maybe it might help for some situations where the MRI is not a 4 or 5, but there's clinical suspicion. Do a PET scan, and then there you go, a targeted biopsy of the lesion that you don't see on the MRI. So we're still interested in PSMA, bringing it even earlier, screening almost.
Okay, so now I think, yeah, we are at the end of the session. Very nice talk and discussion. Thank you once again for Professor Declan Murphy. And of course, Dr. Makaran is already left us in early, Dr. Jeremy Theo. And for the last, I think we are going to make a photo session. Please, participants, to open the video because the organizing committee going to take a video, and we are following the suggestions of Jeremy to publish it on the social media to show that we have a nice discussion, evening discussion, but unfortunately without gathering together and or make a drink or something and makes more relaxed. How about the organizing committee?
Okay, we have 8 page, doctor. So for the first page, okay, wait. 3, 2, 1, smile. Okay. For the second page, 3, 2, 1, smile. For the 3 page, 3, 2, 1, smile. Okay, 3, 2, 1, smile. 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 Okay, it's done, doctor.
Done. Okay, thank you very much once again. It's very nice. Of course, I'm sure we're going to invite you again for Professor Declan and Dr. Jeremy to come to Indonesia for the, I don't know, we hope the COVID-19 dismiss in short time. And so we can gather together, and of course, we are going to have a lot of, not only talk about the urologists, of course, more relaxed situation, and yeah, to make more how do you say it, not more scientific. Oh, of course, in 2023, UA meeting will be in Bali. So that's also my town, or I was born there. So of course we invite you. I'm sure that you will come to Bali in 2023. It's still 3 years from now, but I think that will be a good chance for us to meet each other. So to all the participants, thank you very much, and forgive me if there any wrong in the words or something, and a limitation of our webinar. I'm sure that there are a lot of knowledge that we can get from here, and of course the last thing that we can give more better services to our patient. So thank you very much for all. Good evening. Wassalamualaikum warahmatullahi wabarakatuh. Thank you all.
Thanks, everyone.
Thank you, Professor Declan. Thank you, Jeremy.
Thanks, Jeremy.
Thanks.
Great job.
Thank you.